All right, thank you guys coming for today. And I really appreciate everyone that who participating today, especially with Dr. Boyle and Delaney McGirt from one of our peer student pharmacists. Unfortunately, we had a lot of time conflicts, and because of limited time, we could organize as best as we can. And we really put our things together to share what the provider status bill is about and how we can advocate it for next coming year legislative day, which we are in charge of for Maryland Pharmacy Coalition. And I'll start sharing the slides.
I think you're on mute, Sean.
Thank you. Welcome again, coming to the town hall meeting today. Today we're going to talk about provider status bill. Today we have two guest speakers. One, Dr. Cynthia Boyle. She was a MPHA president 2004 to 2005, and also an author of Leadership and Advocacy of Pharmacy. You can find it from APhA, which was published 2014, and also interim dean from UMSOP from 2014, and she was also president of APhA-ASP from 2015 to 16. And she is a chair of Argus Commission, which from 2020 to 2021, and also professor at UMSOP. And the second guest speaker is Delaney McGirt. She is POS president and also current APhA-ASP Policy and Advocacy vice president. And she has done ASHP summer internship from 2020. All right. So today we're going to talk about provider status bill. And if you don't mind, Dr. Boyle, would you mind take it away from here?
Absolutely. So you all got an email or maybe other association communications about this breaking news. And on April 22nd, the first side of our legislature, our national legislature, the House, as a bill that was, it has since been co-submitted in our Senate. And so we know it as provider status. And I'm going to urge us to kind of broaden our concept of that because our audience is bigger than that. But there are reasons why it's called that. And we want you to get smarter and more savvy legislative affairs. Next slide, please. So what's happened? This is labeled as the Pharmacy and Medically Underserved Areas Enhancement Act. And it does have bipartisan support, Democrat and Republican in the House and also in the Senate. And you probably are wondering why that doesn't say provider status anywhere. And this is following a model from efforts of the nurse practitioners. And sometimes you have to work at things over time. And I don't want to go backwards because this bill has been introduced before, but I think the timing now is really important. And where we can make the biggest input, where we have the most commonality, is looking at medically underserved areas. And we'll talk about that a little bit more. So the idea that this is covering areas of service and Medicare Part B, and you see the word sustainability. So people are not just adding on to dispensing duties. And we'll talk a little more too about how this is based on our state scope of practice. So you see medication management and chronic conditions and point of care testing, tobacco cessation and others, where these services can be enhanced by this recognition and these legislative steps. Next slide. So it is important. We're going to talk as pharmacists and student pharmacists now. We know that pharmacists have value in the healthcare system, and we want to be recognized. So we feel like we're left out and one in. And the idea that we want staff, those aren't any of the reasons that will convince other people that this is a good idea. And this really, let's flip the script a little bit. Tens of millions of people don't have access to basic primary care services. And this is targeting Medicare patients for now in medically underserved communities. And so where pharmacists can work with other primary care providers, it'll be really important for people to stay safe and healthy and to improve the nation's health overall. Next. We won't have many slides. We'll have time for more questions. What I Go ahead, Shonda, that's this one. Medicare provider status recognition. So there are two different concepts here that I want to make sure everybody's really clear about. This is nationally proposed legislation. This is our national senators and our representatives. And you see, when you see bill numbers, HR 2759 and S 1362, these are filed. These are active bills. And I already had talked about what the title of that is. So this is reintroduced. And when I say it is introduced in previous legislative sessions, it has been. We got really hopeful and previous efforts have promoted this. But what is different now is, I think all of you, plus the timing of the pharmacy response in the pandemic, we have been so visible. I've never seen a time when are interested in the logistics of how vaccines are transported or how they have access or the information or the shots in pharmacies, the national pharmacy employers that are promoting this. So that's what's now. Maybe the timing is better. Sometimes it hasn't worked because it was election year. Well, it's not election year. So this may be the case. The co-sponsorship, I'll show you that a little bit more. I checked this morning, there's still 24 representatives in the House that are co-sponsors, and many of our Maryland representatives had been sponsors before. So we'll do some outreach on that. And there's a website there that can help you with more information. There's a great one pager. This happens to be APhA, but ASHP also has some of these. Okay, on the right side here, the state scope of practice is also important. And while if pass, it will really revert to what's in our state scope of practice in Maryland. The service is authorized and based on our laws and regulations. And it's probably getting way ahead of things to talk about fee for service and value-based payments. It's really to be in the game. And I think that's the most important thing, to improve patients' access. That's the benefit. And I want to highlight in Maryland, these medically underserved areas, MUAs, are in all but 4 counties. And so you can go to HRSA. It's really an interactive tool if you want to look up what those are. Baltimore City is medically underserved. So there is so much opportunity to serve people in the state. And next slide. We can't talk about bills and regulations and all that without mini civics. So those of you who took leadership and advocacy, I won't even go that far. What I like to do is to go to congress.gov and I can see the bills. You just put in the bill number and it shows you it's introduced right now. And it'll have to go through House committees and Senate committees. And you see on there that if it's passed and the president signs it. But important for us is to keep track sponsors. And typically we want to, just like you did for legislative day when it was state advocacy, we want to be constituents to these folks who are elected. So this means where you live or work. And I'm not discouraged at all that there aren't Maryland co-sponsors yet. I feel quite sure there will be. And the real purpose, if you want to say what this is about, is amending the Social Security Act to expand Medicare patients' access to pharmacist services. So to me, that's the positive message. It doesn't say provider status. We know that's what it is, but I think our language has to be consistent to the benefit to others. All right, next slide.
Thank you, Dr. Boyle, for that. Yep. Oh, I got it, yeah. So thank you for that great overview of the bill. I want to take just a minute here to go over just an update on the legislative day bills, because this is an excellent example of why advocacy works. As Dr. Boyle was clarifying, this is advocating on a state level for state bills, whereas this provider status bill that's been introduced in Congress is the national legislation. But here, this is a great example of advocating in the state, and it worked. So for those of you that came to legislative day, you may remember there were 2 bills that we were advocating for. One that allowed pharmacists to administer long-acting injectables, and one that would expand the age limit to which pharmacists can administer childhood vaccines to 3 years old and above. And in short, both of these bills have passed both chambers of the Maryland House or Maryland government, and now they're just waiting the governor's signature. So while this is advocacy on a state level, it's a perfect example of why it's so important that we turn out and we advocate for bills. I mean, for P1s who unfortunately haven't had this experience, but when a bunch of students descend on Annapolis in their white coats and they meet with legislators and they tell them, support these bills, this is why this is important, they remember that and it matters and it makes an impact. So while legislative action might seem like, oh, that's something on the Hill, that doesn't affect me, it really does. And when we take action on these things, it really does matter. So congrats to everyone that came out to Legislative Day. This is excellent news here in the state of Maryland.
And this happens every year, right?
Legislative Day, yes, every year, yep. And you know, this year it was virtual for everyone that came. We transitioned it to the Zoom platform, but you know, we still had a presence and obviously this worked. So thanks to everyone that came, and we look forward to advocating again next year. Especially we'll be in charge next year. Yep. Okay, so moving on to how every single person on this call right now can be an advocate. We're going to go through what you can do. This literally takes 2 minutes. It's really easy if you haven't done it already. The first thing we're going to do is go to this website that I'm dropping in the chat right now. This is something that APhA National has put together. And when you navigate to the website, you'll see that page on the right. It gives you kind of a brief overview of the bill, why this is important, and how you can advocate. So essentially, it's a pre-populated email campaign that all you have to do is enter your information. You can go to the next slide, Sean. And the Take Action Now square. And when you enter your zip code, the website is going to automatically populate the representatives in your area. Next slide, Sean. And so once you do that, you can see in this video here, I've entered a Baltimore zip code. And so when it opens up, it's going to populate Maryland's senators, Cardin and Van Hollen. And those are who are going to receive this email. And it's going to populate this pre-written email. Here, if you want, you can make any edits to the email. You can see I changed it to say a student pharmacist because it automatically populates constituent and pharmacist. But you don't have to make any edits. It's already written there for you. APhA has already put all of this together. We know that representatives love to hear from their constituents. If you have, a compelling story or something you want to add about why you think provider status is important, by all means, please add it. But it's this simple. All you have to do is make any edits you want and hit done editing. And you can go to the next slide, Sean. And there you go, you're done. Just like that, you've contacted your representatives and now they know about the bill and they know to support it. And this may seem like such an easy, quick thing, but they really do on the Hill. They count the number of these emails that they get. And when we turn out en masse and we get lots of people signing on to these emails, it makes a difference. They know to look out for it. Representatives are elected by their constituents and they're responsible to their constituents. And so if they're getting hundreds of emails from someone in their state saying, please pay attention to this bill, this is important, this expands, healthcare for people in underserved areas, then it matters and they pay attention to it. So it's really that easy. The last thing I would ask everyone to do is just to share, share, share. You can see there, APhA automatically populates the Facebook, Twitter, LinkedIn, email links. You can put it on your Instagram, tell everyone you know about it. This is so important for the field of pharmacy. This is, an example of where our field has progressed. We're educated, we're trained, we're certified to provide these services, and national legislation hasn't caught up with that. And we're not able to be reimbursed for these services that we're providing. So, as Dr. Boyle was mentioning, this is a bill that's not adding a new scope. It's just recognizing what we can provide and providing reimbursement for that. So please educate everyone around you and share this link so that we can make Congress care about this and get provider status.
All right, so now we are gonna talk about any questions that we have received previously, and also feel free to type in any questions that you may have from this presentation we just had, and we'll discuss about it real quick. I'm gonna stop sharing the slide so we can see people's face and we'll get to like talk better. Right, so the first question we had is, why is that, I mean, this is like very basic information, basic question. Why is it advocating important in pharmacy? Dr. Boyle, why do you think we have to keep doing that even though after like getting a job, like we may have our certain areas that will be practicing in pharmacy, but why is it important to keep doing advocating our profession?
Yeah, how long do we have? It is important for a couple of reasons. Healthcare will change, and you will have views on how to improve either patients' access, do things better, deliver vaccinations, whatever it is. So you have a valuable opinion to share. Our legislators generally are not healthcare practitioners. The other thing is, if we don't do it, on the other side of it is other people will make decisions for us. And they may not understand the practical aspects of a practice of pharmacy, the implications of it. So to be partners, I think will serve throughout your careers. And it's a habit, it is a commitment. You get better at it. This seems really easy, and it is. It can't be the only thing we do, but let's do this. And then we'll see what is the next follow-up and who needs a phone call, who needs a visit when allowed, things like that. I love to see the energy, because this can happen.
Thank you so much. And Dr. Reed, did you have something to add onto it?
Nothing to add. I had a follow-up question, but I can hold on that if anybody else had follow-up to Dr. Boyle's comment.
I think you can go ahead. Thank you.
Okay. So I know this probably isn't going to be an issue for the legislative alerts and sort of sending that one-way communication to legislators or their health aides. But to your point about that follow-up conversation that may happen, what are some of the areas of pushback that people might get from a legislator or a health LA about this issue, and how might people counter that pushback?
Delaney, from your experience last summer, do you have thoughts on that?
Sure. So last summer, I interned with APhA-ASP with their national headquarters, the American Society of Health System Pharmacists, which it's important to point out they've also come out and released a statement in full support of this bill. And so they're really leading this effort with APhA. And, I got to work with some people from their government affairs team over the summer and really just like learn from them how advocacy works and how we get these things introduced. And certainly some of the pushback that we get sometimes is from other lobbies like the AMA, doctors not wanting to feel like, services are being taken away from them. And I think that's where it's really important in the verbiage of the bill and explaining to legislators, this is not taking from doctors and giving something to pharmacists. This is not even adding a new service to pharmacists. We're already doing these things. It's stressing that this is a doctorate. We have 4+ years of education, graduate education, oftentimes postgraduate training. We're certified with the Board of Pharmacy. We're certified to immunize as part of our training. It's just emphasizing that these are services that we're already doing. We're fully educated and certified to provide. This is a bill that's going to recognize that. So it's not a zero-sum game. It's something that pharmacists are already doing. It's really highlighted right now in COVID-19. This is why this is also compelling right now, because it's kind of come to the forefront and it's becoming more obvious, these services that pharmacists can provide. And so it's just saying, we're already doing this. We're certified to do this. Let's get reimbursed for it and let's get recognized for it.
Sorry. Go ahead, Dr. Boyle.
Yes, and I just, at times like that, it's a good question, Dr. Reed. I do rely on my professional associations because I'll often go to fact sheets on the website. And another area where pushback is the cost. What is this going to cost us? And so you look at the CBO score, the Congressional Budget Office, and that's one of the links on that congress.gov. And sometimes things cost, but what is the cost of rampant disease or inappropriate use of medications, illness in our society? It's hard to prove the negative or disprove it. So I do rely on the fact sheets and being prepared before going in on a call, on a meeting. and to highlight the key things. We do have ASHP, APhA has hired people who can help us hone that message. And so they're listening to different legislators. And we can have those conversations directly with Senator Cardin and Van Hollen. And you each have one other representative where you live, national representative. So we'll get better on that message for sure. But for now, it's stirring the pot, it's getting the word out. And some of them will be very familiar that, oh, I supported that before. I'm glad to support it again.
Okay, Dr. Watson, did you have something to say? Yes.
Yeah, so question, comment. So I serve as one of our state's delegates for ASHP. And yesterday we had our regional we had one of our regional delegate meetings leading up to the House in June. And so one of the things that came up in terms of, and Dr. Boyle and Delaney had mentioned, talking about reimbursement. And one of the discussions that we had during this when working on some of the policies was, we talk about getting reimbursement, right? And so some of the things will say reimburse as providers or equity. And so we were playing with wording yesterday. So I'm curious, if there's been any discussion that you, Delaney or Dr. Boyle or Sean, you're aware of, is who should we be paid like? Should we be paid like physicians, or should we be paid like nurse practitioners and PAs who get, I believe, about 85% of what a physician would be paid, right? Because the ideal is not to get paid for incident 2, because that does not equal our hourly rate, right? If you broke that down. So I'm curious if you have any thoughts on that, because I do believe that could be questions that could come up for folks as they are advocating.
I know now currently the bill is 85% of the rate of physicians.
So that would be similar to the NPs and the PAs.
Yeah, and we heard Dr. Rodriguez de Bittner mention the other day that there's also level payment. So she was mentioning that some things would be at level 1, so the least complicated types of interventions. I'm not sure that will service. Maybe that's foot in the door and grow it more later. But you know, some of the people that you interact with will need more advanced care and complicated service. So I do think that value-based payment, so we're not very good at teaching that, but I do big in the future, where the value is the outcome. And insurance companies, I would refer you to the March-April JAFA journal. So Scott Knorr, who's the current APhA, he talked about really payment reform, and provider status is just one of those things. He talks about the well-being and student debt being another, and then for community pharmacists, the intermediary, the PBM. So we have to do and this and that going forward. But I think we'll have to, that's why I was trying to frame this. This is access for medically underserved areas. You know, people can't object to that as much as, well, once you get into the nitty gritty of the payments, it has to be covered. But I think it gets very complicated quickly.
I just got another question coming in asking, what are some of patient care services that the bill focuses on? I think we covered some of that on the slides previously, like such as MTM model. Also, would we have diagnosis codes created for the services we provide?
What was the last part of that question?
Asking, would we have diagnosis codes? Diagnosis codes, yeah.
All right.
No, I don't think so, because that's out of our scope of practice. I can say in the VA, we do check the diagnoses codes, but we're not the ones who are putting them. I always say I practice in the Ivy Tower of pharmacy care when at the VA. Those diagnosis codes are in there. And because it's not in our scope, I do not believe we're technically would be adding them. They would already be in there if I'm correct. Is that right, Dr. Boyle? And then you would click the ones that have already been added when you are billing.
Yeah, and you see Maria's comment in the chat about MPC, the Maryland Pharmacy Coalition, has put together a new task force to review scope of practice and reimbursement. So it is definitely related, but again, access to pharmacist care services.
And I'll just say that, you know, Sean and Maria's currently on that task force. I've been onboarded to it. Sean's going to be on it. So, you know, we as students have a presence on that task force as well. So you know, we have a voice in the game as well. And to the point of who asked about the services that were going to be covered. So APhA's statement, I believe that fact sheet has it too, really does a good job of outlining what services are being covered in the bill. So it's things like MTM, management of chronic conditions, immunizing, point of care testing, those types of things. But they're specifically bulleted out in that statement, if you want to reference that.
Thank you so much, Delaney. What can student pharmacists do continue to advocate besides to the emails that you just provide to how we can do it? Is there any other recommendation do you have, Delaney?
Of other ways that you can advocate?
Yes, as a student pharmacist.
Sure. I mean, certainly the easiest thing is what we just walked through, and then just making sure that everyone around you knows about that. But there are other links on APhA's advocacy website. You can actually set up meetings with your representatives if you want. You can actually call them. You can sign up to get legislative updates from APhA such that you're staying abreast of the news and what's happening with the bill. The congress.gov link that I put in the chat, that also has an option to sign up for updates from Congress whenever something happens on the bill. So I think the biggest thing as a student pharmacist is making sure you're aware of what's happening, staying educated and up to date on the bill. Subscribing to those emails is really easy. I get them directly in my inbox every day so that you're aware of what's happening, and making sure that you're just educating everyone around you, like the public too, not just your pharmacy friends, making sure any patient you interact with or family members understand the value of the pharmacist. I mean, it takes those really that grassroots work to get there.
I think that's a really great point, especially like just coming out to this kind of events as well, like coming to like educating ourselves and see like how other friends and faculties are also involved with, educating our profession also really helps to understand better of like what's available out there. Another question, as a provider, how will malpractices and other regulations work, such as collaborate agreements? The prescribers is covered. Would you mind explain this?
This won't be automatic. So when I mention, this is modifying the Social Security Act, and it covers Medicare patients and medically underserved. So there's those stipulations. We can still work on the other things now. I had reached out to Aaliyah Horton, who's the exec for MPHA, and some years ago we had asked the Maryland Attorney General to answer the question, our pharmacist providers in Maryland. And it was a mixed message that came back, and they looked into the insurance codes and they looked at other regulations. So we can still do this state-based work. Why this is really important too, because ultimately saying that positively this will pass, it is what is in our state scope of practice and our regulations and all of that. So while some insurance carriers, for example, do cover some of pharmacist services, and they still can, there's nothing to keep them. The guidance from a national law like this could help have a cascade effect.
Delaney, go ahead.
So I got a question in the chat to me that I think is perhaps top of mind on some of the student pharmacists' minds, thinking about salary and what we're facing and debt, coming out of school, but wondering if this is something that pharmacists are going to see directly impacted in their salary, or if this is simply something that the company or health system that they're working for is getting reimbursed for. So I don't know, maybe Dr. Boyle, if you can kind of explain that, or any of the pharmacists on the call who have a good understanding of that.
We have to phone a friend here. I see Dr. Reed still beside me on my screen here. This is the scope of practice underscores what your practice of pharmacy will be. And then really ultimately we'll get paid for outcomes. And so if we can improve outcomes for patients, that's a guarantee in a way, but it's not going to be a direct, a line item per se. I think I see Dr. Mansour is on this call too. He's been so active with senior care pharmacists. And while they have a model with consulting, and it's written in that a consultant pharmacist reviews once a month, that these things can be added in when the value is there. So it won't be direct. We still have to work for it. And I'd be glad for anybody else to weigh in.
Yeah, Dr. Mansour, do you have anything to add onto it?
Well, thank you, Dr. Boyle, and thank you, Sean. whether it's going to affect payment directly or not, I think it's important also when you guys graduate and start positions in companies that your employers would be aware of this as well, so that they could advocate on your behalf and on your side. So you also have to remember this is a culmination of so much work that has been done in the past few years, and Dr. Boyle actually has been at the forefront of this, among many others. And you know, so you're actually coming into years and years of toil and work. And so I think it's a more of an ethical or a moral obligation at this point that everyone actually should sign this letter and send it to their legislators as soon as possible. But to answer your question, you know, payments are going to come, I'm sure, but I think, like mentioned before, this is a foot in the door, a good start, and then we can definitely have those negotiations and talks later.
Yeah, I think this is one of those scenarios where it's if you build it, they will come. I think once a mechanism for funding is made available, I think that's when you'll start to see some of the details rolled out on how to direct payments get made. I just can't imagine when money becomes available that large pharmacy organizations, and by that I mean like corporate pharmacies, large health systems, won't start going after that in order to help, you know, fund the care that they're giving, fund additional positions for pharmacists to help deliver more of these services in the future.
I think there was just another question coming in asking, can we anticipate more provider-centered continuing education requirements as future pharmacists after this bill get passed? Also, could future curriculum further reflect preparation for the reimbursement process? Dr. Boyle, do you have answer for this?
So provider-related continuing education, I heard in that first part of the question, and
oh, Dr. Boyle, I think you're muted.
I have to start over. So I heard the first part of that question about you know, more provider status, CE, and things like that. We have learning, and often the employers, you know, we do it for our own, but employers have a great stake in making sure their practitioners are prepared, can be incentivized to do this for different levels of care. So it's both. But yes, I think you feel more comfortable when I think of, we were urging for oral contraceptives to be, you know, part of a pharmacist's scope of practice. Well, that didn't come naturally to people who all of a sudden had more responsibility. They went to get more CE on that so that they were prepared. So that's a natural part of growing the practice.
Okay. Actually, there was another question. Actually, can Dr. Reed answer this if you don't mind? Sorry to put you in the position, but like, would having provider status give us more work to do? And healthcare providers burnout has been a topic. So what do you think about this aspect of this provider status bill?
Yeah, I think that is a really insightful question. You know, there is a relationship between job scope and job complexity and satisfaction. When a job is really simple and monotonous, satisfaction is low because people are bored with what they're being asked to do. And then on the other hand, if it is too complex, if it is too broad, then people aren't satisfied for the opposite reason. They just have too much to do and not enough bodies to go around. So I do think that, you know, we have seen an increase in burnout, given the added responsibilities placed on pharmacists just with things like immunizations. And I recognize that the pandemic is kind of a unique, you know, a unique scenario. It's kind of an emergency. We need to get shots in arms, you know, as soon as possible. But I do think that some of that existed, you know, prior to the pandemic as well. I'd say the one solace here is that the benefit of provider status is it makes additional funding available for these services to be provided. So in addition to maybe expecting pharmacists to provide some of the services that this would allow, there would also be additional money to fund additional bodies to provide more of these services. And so I think there's the potential to offset some of that stress and burnout that people are currently feeling, because their money will be made available to help provide some of these services. So I am cautiously optimistic that this is an opportunity to help alleviate some of the burnout that may exist in the profession.
Thank you so much. And sorry that I asked you like out of blue, but I think that was a great answer. Here's another question. How do we be able to measure the greater preventive impact that we will have to the public as a pharmacist versus solving problems for patients reactively when they present with problems? So it's more about the preventive care. How can we contribute as a pharmacist? Would we be able to do that with the Medicare Part B, or is it something we should advocate in the future?
It's a good question. I agree. Oh, good. Dr. Layson Wilson here too. I agree with the emphasis on prevention. That's a really good point with this, other than the focus on disease. And even with the COVID response, we know that some of the public health resources have been hollowed out up until now. So we're kind of catching up. People who are in that field are kind of glad to see that. So I think the more visible it is, and the idea that pharmacists can take care of patients one-on-one, but also advance population-based goals, I think it'll be both. Going forward. It looks, Dr. Layson Wolford, did you want to weigh in?
Yep. And so that I'm very strongly a community advocate. I think I talk about this a lot to students, and we think about where pharmacists are most public, it is going to be in those community settings. And so I think that we have a unique opportunity to put that in front of our mind when we are practicing in that setting, to say, not only are we providing medications for chronic care, but we are also in a really great position to assist in that prevention, right? And Dr. Reed had mentioned it earlier. I apologize for joining in late, but I think, there's already, I'm sure, a lot of discussion about vaccinations. That is a huge public health impact. I think as pharmacists, and I don't have the data right now for COVID, but I know for H1N1, the pharmacists got the vaccine the last, but they gave 30% of the vaccine. And so we have a huge opportunity for impact and outreach. And I think it's just a matter of, how do we build a structure by which pharmacists have the sufficient time to have sufficient engagement with the patient to provide that education? And I think a lot of that has to do with, one, that compensation piece that's so important, because we're already giving this stuff away for free now. And second, because of those additional resources that Dr. Reed is talking about, can we empower technicians to take a lot of those technical tasks that we have to be able to advocate or to shift our time to more direct patient engagement and care? The last piece, which is not a lot of community pharmacists are used to, is this documentation piece. We will never be able to really, truly represent what it is that we typically do in that community setting without people being willing to do documentation to show what it is that pharmacists do on a daily basis. There's a handful of your P3 colleagues that are going to be going into a new community clinical track that Dr. Tran, myself, and Dr. Osotomehin had put together this year, where they are participating in pharmacies that are participating in Flip the Pharmacy. And Flip the Pharmacy is all about getting community pharmacists to, one, provide particular services in different disease states. Right now, our biggest focus is immunizations. That's not really surprising. But the biggest part is to build a database of interventions that we've done, so that when a payer comes to the table, we can say, this is what the group of pharmacies have done in Maryland and what we're capable of. And we can't do that. We can't do that in mass until everybody takes some time to do documentation. And I know this is really challenging to do now because of the bazillion things that we do in community practice every day. It's certainly going to be a shift in mindset. So how do we support that when people are not technically getting paid to do documentation right now, right? And so I think as students, it's something to kind of put in the front of your mind when you're going out on your clinical rotations this summer, to think about, what are these opportunities for documentation? I know there's a lot of P3s on here. I make you guys do a SOAP note, and you're like, why? My community people never make me do SOAP notes. And it's like, all right, well, here's one opportunity for you to practice. right? And so I think it's a lot of mindset, and to fight against the kind of like maybe opposite messages that you'll hear there in practice. Oh, we'll never get to do this. We don't have time for it, which I agree right now we don't. We do have to change that. But if we don't get this momentum behind it, we're going to be rolling this up the hill for eternity.
So the number of prescription or EHR that we fill in, like are those not enough to show how much work we have done as a pharmacist, or do we need something additional to the document?
Pharmacists are not regularly entering into EHRs.
Mm-hmm.
Pharmacists broadly are not readily able to access EHRs. And so that in and of itself is a challenge. The documentation I'm talking about in Flip the Pharmacy is living in it actually lives either connected to the dispensing system or adjacent to it.
Mm-hmm.
So it is a completely different database than an EHR. That is another battle that we have to kind of wage, is regard to accessing things like CRISP, for example, those centralized EHR systems, so that we can provide better care.
Thank you so much. There's one question that just came in for Dr.
I just wanted to, can I just add
go ahead. Yeah.
Can I just add something, Sean? I just wanted to say that, you know, no matter, just like a plug for all areas of pharmacy, like what Dr. Layson-Wolf was discussing, like demonstrating, and back to the question about demonstrating value, it's really important across whatever area of pharmacy you're interested in. Like, I know in working with ASHP last summer, we had a lot of talks around how to demonstrate value for the health system pharmacists, like what information are you collecting from the EHRs and on the order entry to actually like have quantitative measures to demonstrate the pharmacist's value and impact in the health system. And, you know, back to the question of in the chat of how to demonstrate value in preventative care. If you're interested in managed care, Dr. Boyle talked about this earlier, but there's a lot of research around these value-based models. And so really any area of pharmacy that demonstrating value is really key and really impacts all of us.
Sounds good. Yeah, actually, there was a question about like what do you think about the counter arguments that you may see from community pharmacy that, you know, we are already like overwhelmed by the workload that we have, and there are people who may be against this bill particularly because of that. What do you think? How can we advocate as a same profession? Because like we don't want to like spread our voices to different directions. Like, how can we do that, Dr. Layson-Wolf?
I think that all of that, their concerns, is completely valid. And it's been a very interesting mindset that, you know, as I've progressed in my career and thought about different things that I've advocated for, it's been really good to hear the opposite side of what are the challenges that people are really facing on the ground. Because while we're fighting kind of like on this like ideal territory, right? Like, we're the ones that have the time to go to legislature and advocate. The people who are frontline dealing with stuff every day may not necessarily have that opportunity or feel they have the voice. But I think it's kind of like a chicken before the egg argument. Like we're trying to provide or find a way for us to receive additional compensation, right? So having the opportunity to provide additional services and hopefully be able to advocate for that additional support, and advocating for technicians to have that higher level, pharmacy interns to have that higher level, so they could focus kind of on the technical tasks. Obviously interns, you know, mentoring them a different way, but still, I think that, you know, I don't know necessarily how efficiently we are utilizing technicians to the best of our ability. And it's just a shift in mindset across the board. I mean, that's really what it is, but I think we do have to be mindful about our colleagues who are dealing with this every day. It was my eye-opening when I talked to a pharmacist in another state about the impact what immunizations had on her practice. And you can't deny that. You can't deny that, yes, that just added many hours of work on their already challenging workload in and of itself. And so you just have to ask yourself, how did the organization really work to support their pharmacists when they're bringing in this additional compensation because of the vaccinations? That's something that we have to work on collectively. And I know that we've already started that. I don't know if you guys know if it's already been mentioned, but Maryland MPHA is working on a workforce survey. I apologize if you already talked about this, but it is so important to really gather what it is that our Maryland pharmacists are experiencing with regard to their work environment, so we can work toward these improvements.
Right. Dr. Boyle.
Since we're running out of time, if Scott Knorr were here, I mentioned his commentary in the March-April JAFA. And if he were here, he could make his last statement. And so in substitute, this is a good way to end. The system must change. Comprehensive payment reform will unbridle the pharmacist, unlocking their incredible potential to the healthcare system and to society as a whole. So let's do this. You know, we can talk about what can't work, but we can move forward. And I'm excited that Sean and Delaney and Maria and everyone else has helped lead us to today, to this town hall. And congratulations for being here.
Yes, thank you all for coming today. I know there were questions that couldn't be covered due to the respecting the time, but this won't be the first and the last one. We'll keep having more communications and discussion to raise the awareness and then also advocating for our profession. Thank you again. This video will be updated on the APhA YouTube, so you can take a look at it and have a good day.